So Zeke, we have a lot to talk about, but before we get to life, I want to talk a little bit about death. Because you wrote in The Atlantic 2 years ago an essay titled, "Why I Hope to Die at 75." And in that you argued, living too long is a loss. It renders many of us, if not disabled, then faltering and declining, a state that may not be worse than death, but is nonetheless deprived. Now, I would assume that there are a lot of insurance companies that would agree with you. But in terms of consumer opinion and the way we Americans conceive of ourselves and our sort of robustness in the greatest country on earth, how do you convince the American public that that is a reasonable approach?
Well, I will say first of all, this is the article that keeps giving. It seems to never die. It has obviously, I think, occupied a lot of people's attention. Atul Gawande's book, I think, with the big baby boom generation, people are thinking about their own mortality and what they want to do. But so in 2 years since I published it, there was like 3 different responses. About a third of the people were like, this guy's wacko, dismiss him. They sort of read the title and stopped. A third of the people, it was very interesting, were like, this is interesting, where interesting is sort of that British interesting. It's making me very uncomfortable. I prefer not to think about this. And about a third of the people, a lot of them healthcare providers and a lot of them caring for elderly parents, wrote back and said, I agree with you. I just got a notice from a guy who died at 78 lived in upstate New York, just a little north on the Hudson River. And he said, no flowers, no donations. I want you to donate half an hour of your time to reading Zeke's article. And I was like, wow. And I don't know who this guy was, but I was very moved by it. But I do think part of what I want people to do is to think about what is the essence of their life? What's the meaning of their life? And how does their mortality fit in? Knowing, I think, that we are going to face decline. We're going to face physical decline. But for most of us, the real fear is mental decline. It's the Alzheimer's or other kind of dementia that takes away our ability to have meaningful relationships and takes away our ability to do meaningful activities or work. And that's, at least at this stage of human history, pretty inevitable. If you look at the curves, at 75, the rate of Alzheimer's and other dementias just goes up like a hockey stick. And yeah, maybe you want to risk it and maybe you want to be in that state. But I find it, it's the thing I fear most. I think most Americans fear it. And so my view is concentrate your time pre-75 and then after 75, don't do anything to actively prolong life. I actually didn't say I wanted to die at 75. What the article says, that's the editor's prerogative of giving a provocative title to an article.
Media, once again, is at fault.
But I do think, I think people need to ask themselves, what makes my life meaningful? Almost no one says living as long as possible, unless you happen to be a few of those Silicon Valley guys who think immortality is key. But almost all of us say it's quality. All right, if it's quality, when is the quality not there? And I think it really begins for a lot of people at 75 where the physical limitations really kick in, but especially the mental and the threat of mental limitations. And that deprives you of the things you care about, being with your loved ones in a very interactive way and being able to do work.
Realism in health seems like it's a difficult... The gulf between perception and reality, especially in healthcare, is pronounced, and the consequences of that gulf are fairly extreme. And I want to talk a little bit about some of that as it concerns our American public health.
Well, it's very interesting. If you look at what doctors do rather than what doctors say, they really adhere to what I have. Most of them don't want these interventions. Most of them are much more realistic. But they have a very difficult time being that realistic with their patients, interestingly enough. Now, some of it's probably financial, but some of it, I think, is these are just super hard conversations. I'm an oncologist, so I had a lot of those conversations. And there's nothing more that you dread more that ruins your, if not your week, then certainly the day, which is having to go in and to say to someone, the cancer's growing and we don't have another intervention. And that's just super, super hard. So I think if you look at what they do, they sort of agree with me. If you look at what they say, it's very hard for them to say that to to their patients. I think many people would like that sort of difficult thing to be broken and to actually have that conversation.
But so much of it is rooted in sort of this broader public understanding about the way things are. And I want to use an example of precisely what you mentioned when we talk about oncology. Even if we were to cure all cancers,
Right.
the average life expectancy in the United States would only increase by approximately 3 years.
Yeah.
So why the frenzy around cancer? What are we? And let's first talk about like what other diseases should we be focused on, and then let's get to the other factors that could actually extend life
Right.
and quality of life.
So let me put your quote into context, which is in 1900, the average life expectancy in America was under 48 years. Then over the next 60 years, by 1960, it got up to 69, 70 years, so a 20-year increase. Almost all of that, sanitation, better housing, better food, better jobs, a little bit of that vaccination and antibiotics, a very, very, very little bit of that. And then from 1960 to today, it's gone up another 10 years, so another 10 years in that 50 years. And not all of it, but the predominant big changes in those years from 1960 to today are really two big ones. Almost all of you will get smoking, which is the number 2 intervention. We've decreased smoking from about mid-40s% of the adult population smoke to now 18%. So huge, big benefit from that. But it turns out the number 1 intervention, which almost no one gets, is we've had a very effective decline in our blood pressure and blood pressure control.
It's by 2016 included?
It's
just kidding. That was a politics joke. Okay.
Well,
go
tonight it'll be off the charts. Tomorrow
reverse all our gains.
Stroke rate will be super high. But yes, so it turns out that very cheap blood pressure medications introduced in the 60s had a dramatic effect, even though we're not doing a great job of blood pressure control, but had a dramatic effect in dropping stroke rates and dropping heart attack rates. Those were the big interventions. And it does turn out that healthcare itself, all the services we spend $3 trillion on, don't have that much to do with health and with longevity and with life expectancy. So, you know, doctors gotta be modest about what we can do.
Okay, well, all right. So healthcare, it turns out it's not that important in terms of increasing longevity. You worked on Obamacare, also known as the Affordable Care Act. We focused a lot of energy there. Yes. There's been continued political fighting, partisan battling over that. And then you look at other things like, you know, physical education in school.
Right.
Physical education, physical activity, you tell me, that's an important part of our nation's health, right? And yet, schools are cutting back on their phys ed programs.
Right. So first of all, there are lots of reasons to do healthcare reform other than just the health of the American population. It's good. It reduces bankruptcies and actually puts people mentally at ease that they stress out less about their finances, it turns out, when they have health insurance, which is a very good thing. It does have certain other kinds of advantages for the budget. One of the things people don't comment on even today is the fact that we actually have done a really good job about getting healthcare costs down. Over the last 6 years, they've actually come down. It's not a result of the recession. The ACA has had a big impact on healthcare costs, not by any means done, and that's good for lots of other programs. But you're absolutely right. Simple stuff like physical activity in school, which is so important for kids, to keep them trim, to actually get physical activity as part of their habits, you know, all these important elements of habit formation early on, is being cut back. That's probably the cheapest single intervention. So to put away in your head, and it may have been said already, according to the CDC, 150 minutes a week of moderate physical activity, you know, reduces your cardiovascular risk, your cancer risk, your diabetes risk. Super, super beneficial. 150 minutes a week, which is 30 minutes in the work week. 7 hours of physical activity, and this isn't moderate exercise, 7 hours of physical activity will reduce premature mortality 40%. Just huge impacts. And forget about the sort of mental health impacts, that you feel better. I mean, these are huge impacts, and they're modest. And, the kinds of things we need to do, like exercise in school, like one of my ideas I just heard about was something called Open Streets, which was pioneered in Bogota, Colombia, where you block off streets one day a week. They have a quarter of the population in Bogota, one day a week, going out and riding, walking, doing things in the street when they block them off, block off 76 miles of streets. That's the kind of interventions you really want to see proliferate. And by the way, let me just say one last thing. I think Mrs. Obama deserves a lot of credit. I think her Let's Move initiative has really changed the attitude in this country. I was honored to be able to work on it and help develop it, both around obesity and around exercise. I think there's actually, we're talking about it here. 10 years ago, it wasn't on the agenda, and it wasn't on public fora. And I think the fact that you're just having this fora shows you how the national conversation has changed. And it always warms my heart when we see, junk food and fast food and soft drinks stocks not doing so hotsy-totsy. It does suggest that she's had an impact. And I think that, and look, soft drink makers are moving more to water and to healthy drinks. That does suggest something has changed in the country. We didn't get to this fat problem overnight.
Yeah.
We got to it over 50 years, but and it'll take us hopefully not 50 years to change, but but we are in the change, and I think I'm quite positive about the future.
In the interest of full disclosure, my husband was the executive director of the Let's Move program and has been involved in all of the initiatives that you're talking
Sam
about.
and I were
Yes.
Partners in crime.
How do you think I got this moderating gig? I'm kidding. But when we talk about, Bogota, I just think in this moment, and maybe it's a passing moment, if you were to suggest, let's close down some more streets in New York City or any other major city and open that for public recreation, you would have huge backlash. Business owners would say, we're going to lose revenue, we're going to lose income. You'd have people that don't like the nanny state getting involved.
Right.
And I go back to the schools question. How do you convince a school system that it is detrimental to the health of a nation to get rid of a physical education program without that argument getting folded into this heavy hand of the government narrative?
Well, first of all, I'm not sure the closing the streets actually is bad for business. I think at places that have done it, it's turned out not to be bad for business. I would note that, secondly, there are places that have closed streets, and I mean, Washington, Beach Drive gets closed every weekend.
Right, but there are no businesses on Beach Drive.
There are no businesses, but it does bring out people. And I think there are streets that we have closed. And I do think it's something worth trying and seeing. I mean, I'm sure there are economic evaluations of it. It's got to be a better investment than football stadiums, which are negative investments for most municipalities. You spend billions and you get nothing in return. In terms of economic activity. But I do think we need to think of health in a broader context. I'm probably not the big advocate for everything needs to be evaluated by its impact on health. But I do think the idea that we're cutting back on schools and paying at the other end, where the other end is only a few years down the line in terms of adverse health, makes no sense. So one of the things I am excited about in terms of healthcare reform, and it's not really in the ACA, but I think the way the ACA is driving things is you will see big health systems like Kaiser, like dominant insurers in states, begin to work closer with schools because they do need to save money over the long haul. And one of the things that they can do is get much more involved in school. And by the way, from my standpoint, physical activity is absolutely one of the essential things schools need to do, but I also think schools are great places for mental health. We are, in this country, I think one of the biggest tragedies we have is that are lost to the health system are adolescents. They're physically healthy, and so we sort of pay no attention to them. Turns out their mental health ain't so hotsy-totsy in America. If you look at their rate of premature death in America among adolescents, car accidents, suicides, et cetera, it's super high.
Is it going up?
I don't know whether it's going up, but it's super high compared to the rest of the world. And that suggests to me, a car accident some of it is just a car accident, some of it's a real mental health issue, drinking and driving, just driving way too fast, which is a sort of frustration issue. We need to focus on them. And I think, again, schools are the best way in to sort of look at that. So I think that there's a lot we can do, and let's, as long as we're talking about schools, early childhood education, 3-year-old mandatory pre-K, it's universal in France. France any richer than the United States? No, right? They, interestingly, do have a very high investment in young kids, and their health system does, by all metrics, much better than our health system. And I think a large part of it's got nothing to do with the health system. It has to do with the fact that they are very focused on daycare for kids, early childhood interventions, universal pre-K. And there are modest things we can do to I mean, these aren't very expensive. It turns out they're not that expensive, and we can finance it. As Philadelphia showed, soda tax, take that money, put it into pre-K, universal three-year-old education, improving parks, et cetera. That's a deal it sounds like the American public is now beginning to pay, or willing to pay.
In Philadelphia, I believe the mayor didn't make it a public health issue. He made it a revenue raiser issue.
Yes.
Is that the way to approach something like a soda tax? I mean, do you think that we'll ever get to the point where we have a national soda tax?
No. Until we have a lot of local soda taxes that drive the soda manufacturers nuts. I mean, right, when do you get national legislation in the United States? When does business say, oh, come on, Congress, pass this, please, for me? Is when you get a lot of local stuff, it looks hodgepodgey, and they want it more uniform. It makes it easier for them to do business. We saw this with emissions and the car companies. You see this in, when we have a lot of experiments at the state, it becomes hard for business to run the gauntlet, and they want some national floor or some uniformity. I'm sort of pessimistic about it. Your husband and I got a lot of scars over trying to advocate a soda tax during the ACA as a financing mechanism. And, it just wasn't popular, and it might have sunk the whole thing, and so it wasn't politically worth it. But I do think it is interesting that you're now seeing a lot of locales and maybe even states try the soda tax. I mean, it's another sin tax. Let's put it. It's like first we did the smoking, right? We did tobacco taxes. Then we did gambling, right, to raise revenues without raising taxes. Now it's marijuana in some places, and soda tax is the next, where you can raise revenue without actually raising revenue, or look like you're raising revenue, and put it under some other guise. And so I think it's inevitable that it's going to proliferate. Its health impacts, if we're going to be honest, we're not 100% convinced. It does decrease drinking, whether that decreases overall calorie consumption, decreases BMI. I think the jury is out. One of my colleagues, one of the people who works in my department at Penn, Christina Romero, who's a very young, not very young, she's a young up-and-coming, someone you will all hear about, I'm sure, in the next 5 years, researcher on food policy, is conducting a study in Philadelphia about the health impacts of the soda tax. And so she's a superb researcher, we'll have a definitive answer, I'm sure, in the next 5 years.
Do you worry that because of the stagnation in terms of getting federal legislation passed, that's being euphemistic.
Gridlock, I think, is the word.
Yeah, sure, whatever you want to call it. And as you said, so much is being driven at the local and state level, that we're increasingly emerging into an American landscape where we have red states and blue states of health. You have blue states where there's greater sort of networks, resources, awareness, policy that supports better health outcomes, and then other parts of the country where that's not the case. And that which truly gets to the life part of quality of life, drives us further apart, when really life actually is better for some people living in certain parts of the country than it is for others.
Correct. Well, that has been true for a long time. It has been true that we have had different life expectancies, different collection of diseases for a very, very long time. I mean, if you look into the 1930s, not that long ago, things like hookworm and roundworm and, diseases that we call neglected tropical diseases, they're now only in Africa and those places, were pervasive in the South and the United States. And we did get rid of them, but we do see a very big divergence in states, but also even within states. You see, and it's especially pronounced in income inequality, as we saw the Chetty study, I don't know, about 4 or 5 months ago in JAMA, showed you that, income inequality are leading to life expectancy inequalities. The best solutions for that are to target those illnesses and conditions that people of lower income status have, which is smoking, predominantly lower income. I mean, almost none of the people in this room smoke. They probably know one or two people who smoke at most. We've gotten rid of it, essentially, from upper middle class families. We have to do that for people of lower income status, and taxes are, whatever you want to say, taxes are a really effective way to do it. A 50-cent increase in taxes will decrease smoking among young people 4 to 5%. And if you don't smoke by 21, you're almost guaranteed not to smoke in your life. And so we could do that. Is that regressive? Well, it is the fact that poor people who are smoking will pay, but it's also progressive in the fact that, yes, poor people will not start smoking, and that will be a good thing. Similarly, soda tax, I think we have to evaluate it. And again, I come back to this early education, early intervention stuff. One of the things which I'm very proud of that we got in the Affordable Care Act but needs to be expanded and put on steroids is these nurse-family partnerships, which is where a nurse visits a first-time poor mother to help her prenatally and then in the first year of life of the kids. Incredibly effective program from every standpoint, reducing premature births, reducing infant mortality, and you get positive economic returns for every dollar. But we only have 115,000 mothers on the program because of funding. This is a situation where I often like to say, all right, let's raise tobacco taxes, put it to make this nurse-family partnership universal, and we'll have a huge impact. We'll decrease smoking-related problems, we'll increase the wellness of these poor kids coming out. It's like, this is magic. Where do you get these kind of interventions? And as the Center for American Progress showed, it's nationwide, it's an $11 billion investment over 5 years. It's not really, we're not talking about super amounts of money, and it really positive net returns to the government. So if you ask me, what's a single thing we could do? That kind of program, to direct it, making it mandatory part of Medicaid, that's a huge, huge positive in terms of public health, in terms of education, all sorts of things that we all care about, and it's not expensive. Now, can we get it through Congress?
Right.
I think this is, I'm not the political brother, as I like to say. But I do think that there's going to be a short window in the first year after the election where the Republicans are going to want to, assuming Mrs. Clinton wins, which I think is going to happen, where...
There's a chuckle from the audience.
Yes, well, where you'll have the opportunity to cut to a deal. Because Paul Ryan, as Speaker of the House, cannot look like he's totally intransigent, and I think he's going to have to look like he can do things. He has his own agenda, taxes and stuff. And if you put everything together, you might have this grand bargain where some of these things might be possible. Because, look, early childhood interventions that save money on Medicaid, those are things Republicans generally like and can come to
Especially
like.
Fiscal conservatives.
Yes.
On that note, we have a couple of minutes for questions from the audience. If you want to raise your hand right back here, I think there are floating mics. If you can just state your name and maybe keep your question succinct.
Thank you. My name is Mina Marifat. I work about cities with design research and teach at Georgetown, again, about better cities. One of the things that I noticed absent in the discussion this morning is technology. And maybe because I'm from MIT and we just had a discussion this weekend, I would like to raise the issue that how many people in this audience are wearing a Fitbit? I'm sure a good number, and the mayor mentioned the Fitbit, but in fact, there are other instruments. Rosalind Picard, a professor at MIT, who has invented Empatica and other things. She invented a bracelet that is recording the emotional state of people. And that has helped not only, it's actually being looked at for the FDA, but it actually is really because the depression has increased so much among all populations.
Okay, let me confess right from the start, I'm a techno-skeptic. That doesn't mean that there's no role for technology. But if you look at least today, in 2016, there's not a ton of evidence that these technological interventions have really transformed anything. There's no evidence that the Fitbit does you any good. I don't wear a Fitbit, and the reason I don't wear a Fitbit is, yes, I know I do 10,000 steps a day, plus or minus 2,000, and knowing that I do 12,000 one day or 8,000 makes no difference. What is the problem? It's not getting that information. It's the effector arm, as we like to say in biochemistry. It's how do you get people to change their habits? And there, I'm very much less convinced that it's technology and much more convinced that it's face-to-face personal interactions. Now, another techno-skeptic. There are two of us in the room. Usually these crowds are like full of techno-utopians.
And not Luddites like you.
No, I'm a total Luddite, as you well know. So I think the question is how you marry the technology with how you intersect with people to get them to change their habits. Changing habits are hard. We all know this, right? We all make New Year's resolutions. Almost none of us keep them, right? That's the hard part. And I think that's less going to be technology-driven and more person-driven, and we have to figure out how we get the person-driven change. And so that's where I would focus my attention. I'm not against the technology, but we have to recognize it supplements the human interaction. It's not the solution to everything in the world.
Next question over here.
Hi, my name's Will Tucker. I'm with Advocom Group. I was just wondering if you could return to the schools bit a little bit, and you talk about syntaxes and these policy levers we can pull to incentivize or decentivize, particular health problems. When it comes to schools, and especially around mental and behavioral health policy, it doesn't seem like there are quite as many levers necessarily that government can pull to incentivize particular programs. I want to draw attention to the fact that I just read about Northern Michigan University, which has a student code of conduct that, in fact, says that students should not discuss potential thoughts of self-harm with their classmates because it might harm those classmates' educational experiences. And if students discuss thoughts of self-harm with their peers, they are actually potentially subject to disciplinary action. What on earth can we do from a policy-making perspective to incentivize smarter educational, mental, and behavioral health policies so that peers can talk and work toward this together?
Just a note, I'm sure this is part of the broader debate about campus speech, but go ahead.
Well, actually, it's interesting because I think there are two things going on campuses. So I'm a vice provost at the University of Pennsylvania, and almost all these things pass my desk one way or another. The whole issue of, there are three things that our campuses are really focused on now. One is the free speech issue, one is sexual assault issues, and one is mental health. We spend, they're all very, very high priority. I will say that most campuses now have a very, very serious focus on mental health issues. The suicide rate on campuses is real, and I do think people are taking it seriously. That doesn't mean the response is always the most enlightened, and I don't know that there's a specific federal or state policy that is really going to solve that problem. I do think that it is figuring out the right solutions. We spend a lot of money on mental health issues, and we haven't gotten our suicide rate down to zero, and there's no major university or campus that has. But I do think this focus on trying to do better by students and also trying to, a lot of the anxiety is not about classroom stuff, it's about long-term career stuff, and I think that is part and parcel of our social anxiety about where the country is going and will I have a job in the future. And I think we need to decrease the pressure on students regarding those bigger social factors, because I think that's where a lot of it comes from.
We have to leave it there. I'm sorry, we are out of time. We could talk to you, Zeke, America's Doctor forever, and maybe I will later in another closed venue. Thank you all for coming.
Thank you
for your time.